So good afternoon to all of you, all offline and online delegates. And you people are making this conference successful. And I'm really honored and humbled to be standing in front of you. And hopefully I'll do the justice to such a vast topic, which all of you must be knowing there, the books and everything being written on it. Before that, I think I would like all of you to just stand up for a moment. Refresh yourself and just clap for the organizing team. For the department, for the staff development, and for our sponsors and the people from the Hilton and all the staff and everybody who is working in front and behind. So thank you once again. As I said, we have been dealing with the infertility since morning, and we have heard so many lectures, and now the baby is to come. And as the Dr. Yasmin said before, it's not important the biochemical pregnancy or the first trimester or whatever it is. We want to have a take-home baby, so the live birth rate. So there are patients who suffer from the recurrent pregnancy loss. So I know it's a vast topic, so I'll be just touching the main points. And I'm thankful to Dr. Nisha and the other team giving me this topic, because it has made me also learn a lot, which I was not knowing. So overview of my presentation is introduction. What are the challenges in dealing with these patients? And what's the definition and etiology, management, and summary. As we all know, the 1 in 5 pregnancy ends up into pregnancy loss. And knowing the etiology at least serves a purpose to the couple. Like if I know what is the cause of my pregnancy loss, I feel emotionally and psychologically better. Maybe I have an option to deal with it. But when there is a pregnancy loss occurs, there is a significant negative effect on the life, and the repetitive nature, which is why it's called the recurrent pregnancy loss, may intensify the grief experience. Studies, as we all know, they are all focused on women, but we need to look for the men also. And this is a conference, I can see only 2 men sitting here, and maybe 2 here. Clinicians, when we arrange the clinic for these patients, so we need to see the psychological need of the couple while arranging the services for them. What are the challenges? The main challenge is the definition. All over the world, there are different definitions, which are, some people will say 3, some people will say 2, some people will say consecutive, non-consecutive. That is still a problem. There are no incidence studies because it's very difficult to define. Somebody aborts at home, somebody aborts in the hospital. So from where you get it? So we only have the prevalence. The incidence is not known. Although it said 6% to 2.3%, more than one factor can exist. This time I abort because of the infection, the next time because of the congenital anomaly, third time something else. So it's difficult to define. There are lacunae in the literature, because it's very, very difficult to conduct the randomized control trial because of the ethical and the social reason on these type of patients. Natural background risk is always there, which will again affect the expected results. And it does share, there's an overlap between infertility and the recurrent pregnancy loss. These are the different definitions. We can see this pointer. Thank you. So if you go by RCOG, they include all the pregnancy, whatever it is, biochemical, non-biochemical, whatever, up to 24 weeks and 3 consecutive abortions. If you go by American guideline, there's a clinical pregnancy. It is being said that means either it is histologically or by ultrasound, it is proven. And the only mention that majority is the loss is prior to 10 weeks. There's no definite gestational age, and it has to be 2 consecutive ones. If we go to ISHRAE, it is serum or the urinary SCG positive, but it excludes ectopic and molar pregnancies up to 24 weeks, and it can be consecutive. 2 abortions can be consecutive or non-consecutive. Unfortunately, for ISHRAE and RCOG, for both, the new guidelines are going to come for this recurrent pregnancy loss. So definition, what we have been following with us, it's more than 3 laws. It's a primary one where there's no live birth or anything up to 20 weeks. And the secondary, when there is a pregnancy which has progressed beyond 20 weeks, and it may be live birth or a stillbirth. Why I'm saying 20 weeks? This is as per WHO guideline, which says up to 500 gram we take the baby, less than 500 gram we take the baby to be as abortion. But which usually corresponds to 20 to 20 weeks. And in Oman, we follow this definition of stillbirth. So what happens when the patient comes to us of these type of this thing? So the questions come, why did it happen? How can it be avoided? And will it happen again? So we have to answer these questions to the patient. Risk factors, so which, as we know, the maternal age, as the age advances, the quality of ova, the number of ova, they decrease. So the chances of abortion is more. Previous miscarriages. The more the number of previous miscarriages, the more chances of having miscarriage again. If there are 3 consecutive miscarriages, it is being said it is 40% chances of pregnancy being going for abortion. Obesity, it can lead to both spontaneous or recurrent pregnancy loss due to different problems. And the other environmental factors can also lead to recurrent pregnancy loss. This is what you can see. If the patient age is around 40 to 44%, it is 51% chances of the miscarriage, spontaneous miscarriage. And if it is more than 45, it is up to 93%, as it was discussed in the previous lecture. These are the various causes. As we know, still the 50% will be unexplained. The others are genetic, anatomic, autoimmune, infectious, and endocrine factors. How do we evaluate these patients? The main important thing in these cases is the gestational age at loss, because that defines the cause of the problem. And then we have to do, as it has been said, the history, examination, and everything, and information from the previous lab pathology and the imaging studies is very important. Examination is the general examination and the gynae examination. And the most important thing in these patients is the mental health evaluation, because these patients are psychologically very, very disturbed. And if she, with disturbed psychology, if she embarks on the pregnancy and she has a pregnancy loss, there are chances of going her into depression and other problems. Coming to the cause, like the genetics, 2 to 4% is due to balanced structural chromosomal problems. And there can be single gene defect also, which is not that common. So chromosomal microarray analysis of product of conception is the only test which can define the definite cause behind the miscarriage. And these patients should be given genetic counseling. And it's now in Salalah, we are happy because we have a genetic clinic and we can refer the patient. And even in the private, if people are having such cases, they can be referred to the genetic clinic. Coming to the thrombophilia that we all know, the mainly responsible is the acquired thrombophilia, which is also called an antiphospholipid antibody syndrome. This is the most treatable cause of recurrent pregnancy loss, and it is quite evidence-based. And up to 15 to 20% of women with RPL has APL. And other population, the general population, only it's 2%. And this is also seen in cases of early onset of severe IUGR and severe preeclampsia. These are the various indications. I think all of us, we know in which cases we tell them this is a patient. Either they have to be a one clinical criteria and one laboratory criteria. And it is the laboratory criteria, it has to be medium to high, and twice it has to be done. There we get the lacking. We just get one report, slightly positive, mildly positive, and we start the treatment. No, that should not be done. So just now we had a nice lecture on the uterine, the fertility surgery, and in which the uterine anomalies were included. So congenital anomalies, they are around 13.5% as compared to the 5.5% in unselected population. High-risk population, uterine septa are the most common. But most of the people with congenital uterine anomaly have a good outcome. Cervical insufficiency, it is estimated to be 0.5 to 2%, and it's responsible for about 15% cases of the habitual abortion between 16 to 28 weeks. Coming to the infection, there is no infectious agent that has been proven to cause recurrent pregnancy loss. It is maybe caused to be sporadic, especially in cases of toxo, chlamydia, listeria. And as we all know, the rubella, cytomegalovirus, herpes, they can directly infect the fetus and the placenta, so they can be the pregnancy loss. Bacterial vaginosis in the first trimester can cause the second trimester miscarriage and the preterm delivery. The ongoing chronic endometritis and the recurrent miscarriage trial is going on. I hope it will give us some answer. And there are patients who are found to be positive for chronic endometritis are being given 100 milligram of doxycycline for 14 days, and their pregnancy outcome will be compared. Coming to the metabolic and endocrinological factor, one of the very important one is thyroid dysfunction. Or nowadays, I'm seeing in the private and even in India, I saw that even in the pregnancy booking, the TSH become as a first test, like as a basic test at the time of the booking. Because the thyroid, it helps in the fetal development. PCOS, we have been discussing since morning. It causes, we can say, the increase in LH, obesity. It can cause GDM and hyperandrogenemia. So many things it can cause, so it can affect. Diabetes as such cannot be a cause of recurrent pregnancy loss unless it is uncontrolled. Hyperprolactinemia. Prolactin is needed for it's taken as an ovulatory function. So if there is a dysfunction in that, then again, there are chances. Ovarian reserve testing, as such, it is being said not to be done. But in cases of recurrent pregnancy loss, it has been seen in a recent systemic analysis in 2020, which says that the lower reserve correlates with the pregnancy loss. Luteal phase insufficiency, difficult to diagnose. Androgen, if they're hyperandrogenemia, because they will hamper the endometrial development. Vitamin D, it can cause the obstetric and the fetal complications. And there are a lot of studies being done on the vitamin D, and we have found that especially in the Gulf region with the full of sun, it's almost 80 to 90%. Luteinizing hormone, more than 10 in the middle follicular phase is supposed to have a negative impact, but still there are studies which are not confirming, and the definition is also not very constant. Hyperhomocystinemia, because it can cause thrombosis. If it is there, it needs to be treated. After all these causes, the remaining 50% are still the RPL but prognosis is still good. And 50% of these cases, without any treatment, just with the psychological support and a dedicated clinic, can have a live birth. As we know, we have been discussing the factors affecting the pregnancy loss. It is multifactorial. So the management also has to be multifactorial, including the lifestyle modification, psychological support, and specific treatment for any identified cause. This is one of the just a summary of the investigation which need to be done in these cases. If genetic, karyotyping, if anatomic, we need to do the sonography and other things. Thrombophilia, we need to do for the acquired, inherited, if required. Infection, if required. Immunological, thyroid function test, and the antibodies, especially the TPO antibodies, and prolactin and HB1AC if needed. And in the male factor, the sperm DNA fragmentation factor index. Coming to the particular management of each condition, like we have already dealt with the genetics. So coming to the anatomical, we have already discussed. And the cervical cerclage as per guideline, if needed, in the recurrent pregnancy loss, especially in the second trimester or the preterm birth. And improve live birth rate after treatment for the fibroid that distort the uterine cavity. Hysteroscopic septal reduction division reduces the pregnancy loss rates, but the lack of high quality evidence of the efficiency and the safety of surgical treatment, they should only be offered to an individual basis by experienced people. Coming to the hypothyroidism, again, as I said, this is one of the important factors. So we should be doing TSH and TPO. And if it is normal, then we should be doing the T4. That blanket doing TFT, T3, T4 and everything is not indicated. And if you go to the hypothyroidism, its association is found only with the sporadic loss. And it is said to be a contributing factor and we need to treat it. Subclinical, it is unknown if it is effective, the treatment. It is being said, if TSH is more than 4, you should treat it. But if TSH is 2.5 and thyroid peroxidase antibodies are positive, then it needs to be treated. And hypothyroidism, it's not much. And for these antibodies, actually, we need more studies. Immunotherapy, which came in a big way, but it has gone down again. Paternal immunization, third-party donor leukocyte, trophoblast membrane, and IVIG, that is intravenous immunoglobulin in previous unexplained RPL, does not improve the live birth rate. So these things are not to be done. Coming to autoimmune ones like hereditary thrombophilia, again, the screening is not needed. I remember when I came to Salalah, we used to send all these patients to Dr. Saifuddin. And later on, we decided, no, they should not be investigated. So these cases are not to screen for thrombophilia unless in context of research or the woman with additional risk factor for thrombophilia, like history of thrombosis or anything. Regarding the management of these cases, as we know, these patients are very desperate, something to be done. There is no evidence of use of heparin in these cases in first trimester, but some studies have reported that it is useful in second trimester. Acquired thrombophilia, which we have been treating always, and this we can say it is association is there. It is a contributing factor. The prognosis is good if you treat, but still the evidence is weak. When to start the treatment? This is the question we usually face in the OPD. Dr. Veena, can I start aspirin for her? Can I start heparin for her? So once aspirin can be given when the patient wants to get pregnant or getting the treatment, and the heparin should be started when the cardiac activity is documented on TVS, which is usually around 6 weeks. Newer concept, for this, I'll thank Dr. Anuja because she started asking me one question and I could not answer it. That was use of hydroxychloroquine. Then I searched the literature and I found it. See, it is being said that the APS is not only simply the thrombotic disease, but it is also an immune inflammatory disease. This is the new concept coming up. And a study of anticoagulant and anti-inflammatory together. The anti-inflammatory has an embryo protection effect, showed a better outcome than only the low dose aspirin and low molecular weight heparin. Hydroxychloroquine, which has been well tested in pregnancy, because so many rheumatology patients, they are getting it and nowhere any problem has been found. So when it is being given 200 to 400 milligram OD from conception till 20 weeks, SCQ has anti-inflammatory and anti-thrombotic effect, and thus may improve the pregnancy outcome. And as we all know, the pregnancy, there is a modulatory immune response. The change in the immune response of the mother to the fetus makes the mother and fetus go together. So it is being said the low dose cyclosporin as immunosuppressant in refractory cases of RPL also being coming up. Immunological screening, it is being said the anti-nuclear antibodies, also there is an association has been found, but whether it's a contributing factor or no, we don't know. And the prognosis and treatment is not available. Then the natural killer cells, there's insufficient evidence to recommend natural killer cells testing of either peripheral blood or endometrial tissue in women with RPL. Male factors, we have to assess the male factors, the lifestyle modification, the paternal age, smoking, alcohol, and all those things, exercise pattern, the excessive exercise to be avoided, and the obesity to be taken care of. Assessing DNA fragmentation in the couple of RPL should be considered because there is association. It is taken as a contributing factor, but it requires further studies. Our beloved progesterone, we keep giving in all the forms, oral, vaginal, injectable, but there's insufficient evidence to evaluate the effect of progesterone supplementation in pregnancy to prevent miscarriage. Progesterone is responsible for the immune cascade of pregnancy, and it's also immunomodulatory. Therefore, in absence of any other factor, progesterone is given till placenta takes over the luteal function, that you can say up to 12 weeks or 16 weeks. The types of progesterone, as we all know. This was a meta-analysis done recently, which has shown that the progesterone has a little beneficiary effect, not more. In unexplained cases, vaginal progesterone may improve the live birth rate in women with 3 or more pregnancy loss and the vaginal loss in a subsequent pregnancy. Insufficient evidence to recommend intralipid therapy for improving the live birth rate. There is no evidence to recommend granulocyte colony stimulating factor, which is known as GCSF. There is no evidence to recommend endometrial scratching. There are some non-conventional treatment for RPL, like Chinese herbal treatment. There are data there, but they are not very much clinically proven, and the safety of the medicine is also not proven. Acupuncture, IVF and XI. Huh? Sorry? Okay. Diet and antioxidants, other treatments like homeopathy. And this is something new I heard. I don't know any one of you have heard this. Bioresins and neprotechnology. The bioresins is an electromagnetic treatment to fight with the chronic disease. And this is natural proactive technologies. There's no clinical data. I'm not aware of it, but it is there. So the treatment protocols, all patients to be offered supportive care. And the most important thing, we should have a dedicated clinic, which improves the outcome. Supportive care, that is a tender loving care, gives a good answer to all the outcome, and it is established in most of the cases. We need to have a psychological support, and at first consultation, we should have it. Early ultrasound examination, maybe admission if needed, and relaxation tapes. So to summarize, in all the category, whatever is the cause, when the supportive care was given, the outcome was always better. Recurrent pregnancy loss is a heterogeneous condition with a numerous causes. So we need to have a multidisciplinary approach. And managing patient recurrent pregnancy loss in a specialized clinic leads to best results. So it's time to start for us the recurrent pregnancy loss clinic. So this is the summary of the management. After second miscarriage of first trimester loss, the workup includes the screen for weight extremes, alcohol and smoking, cavity check, that is by ultrasound, antiphospholipid testing, and endocrine testing. If there is a problem, the manage the abnormality in 1, 2, 3, and 4 accordingly. Consider prophylactic vitamin D supplementation for all and provide psychological support. Then the fifth one is the cytogenetic analysis. If it comes out to be aneuploid, nothing to be done. If it is euploid and there is an abnormal cavity, endocrine etiology, or anything is there, it needs to be addressed. And after that, again, the expectant management. If the no cause is found, that becomes an unexplained cases. And if it is unbalanced translocation or anything, we need to do the parental karyotyping, genetic counseling, and considering PGT versus expected management. Regarding unexplained cases, we have to go further. We have to do complete workup with expectant management. Consider hereditary thrombophilia testing. Only if familial or personal history of VTE. Consider sperm DNA fragmentation testing. Consider parental karyotyping. Consider luteal phase deficiency testing. Consider chronic endometriosis testing, and consider hysteroscopy if there is a history of uterine surgery. After third miscarriage, if there's no testing has been done so far, investigate and manage according to the above. And if it has been already done, previous miscarriage, repeat the POC chromosomal analysis and full workup already. And if all possible etiologies have been addressed and POC in euploidy is repetitive, consider to go for PGTA. This is the summary of protocol of the recommended treatment. As I've said, should I read it? I have 1 minute. Oh, thank you. So if they are chromosomal, this is just a summary, whatever I've talked till now. So if chromosomal abnormality, we go for PGT for structural rearrangements. And if individually assessed for PGTA, if they are anatomical abnormality, we need to the surgical management of fibroids. And we have to assess individually for surgical correction of the uterine septum, polyp or adhesions. And surgical, there's no evidence surgical treatment to other Mullerian abnormalities. Thrombophilia, we give heparin and low dose aspirin, and there's no need to treat the congenital thrombophilia. Infection, antibiotic, and if there, so we treat the infection. There's no role of prophylactic antibiotics. If we go to immunological, like if it said the prednisolone and all, no role, but there are studies coming up with prednisolone and HCQ regarding the immunological factors. Then endocrinology, there's the treatment of diabetes, treatment of overt hypothyroidism, and treatment of hyperprolactinemia. There's no need for the treatment for subclinical hypothyroidism or thyroid peroxidase antibodies, androgen or HCG. Male factor, lifestyle modifications, and individually assessed, some antioxidants can be given. Unexplained, the progesterone need to be given. In general, we have to maintain a normal BMI, stop smoking, vitamin D, tender loving care, and dedicated recurrent pregnancy loss clinic. Okay, limit the caffeine to less than 3 cups per day. These are the references. Thank you very much.